Cardiac arrest is one of the most critical emergencies encountered in medical practice. It demands swift recognition and immediate action, as every second counts. Medical personnel are trained to respond rapidly, but anyone can make a difference with prompt intervention. In this video, we'll explore what cardiac arrest is, why it happens, and how life-saving techniques like CPR can dramatically improve survival rates. Understanding the basics of cardiac arrest and the steps to respond can empower you to act confidently in an emergency. Let's begin by defining cardiac arrest and its significance. Cardiac arrest occurs when the heart suddenly stops pumping blood, depriving vital organs of oxygen. This condition is broadly defined as the inability of the heart to sustain an effective output. Without circulation, organs like the brain and heart quickly begin to suffer damage. Cardiac arrest is not the same as a heart attack, though both are serious. The key difference is that cardiac arrest involves a complete cessation of heart activity, while a heart attack is caused by blocked blood flow. Recognizing cardiac arrest is essential for timely intervention. Cardiopulmonary resuscitation, or CPR, is an emergency technique performed to manually preserve brain function and restore circulation and breathing. CPR is indicated for individuals who are unresponsive and not breathing or breathing abnormally. The procedure is continued until spontaneous circulation returns or the person is declared dead. CPR acts as a bridge, keeping the body alive for defibrillation and advanced life support. Studies show that immediate CPR, followed by defibrillation within 3-5 minutes, significantly increases survival rates in cases of sudden cardiac arrest. Cardiac arrest can result from a variety of causes. Common cardiac-related factors include coronary artery disease, valvular lesions, cardiomyopathies, and heart blocks. Other causes include hypoxia due to respiratory issues, hypotension from massive blood loss, hypoglycemia in diabetic patients, fainting during anesthesia, drug effects such as intravascular injection of adrenaline, and electrolyte imbalances like high potassium or calcium. Understanding these causes helps in prevention and rapid diagnosis, which is crucial for effective management. Beyond the primary causes, cardiac arrest can also be triggered by vagal reflex mechanisms during intubation or surgical stimuli, terminal stages of diseases like diabetic coma or malignancy, and complications from anesthesia. These factors highlight the importance of monitoring patients closely during medical procedures and being prepared to respond to sudden emergencies. Awareness of these risks can help medical personnel and laypersons alike anticipate and prevent cardiac arrest in vulnerable individuals. CPR is performed to oxygenate the blood and maintain cardiac output, keeping vital organs alive. The procedure generates a pressure gradient between arterial and venous beds, facilitating blood flow. The brain can sustain damage after about 4 minutes without blood flow, and irreversible damage occurs after 7 minutes. If blood flow stops for 1-2 hours, body cells die. CPR is most effective when performed within 4 minutes of cardiac arrest. Low body temperatures, such as in near-drowning cases, can prolong brain survival. Effective CPR delays brainstem death and keeps the heart responsive to defibrillation. Diagnosis of cardiac arrest relies on several key signs. The absence of a pulse in major vessels like the carotid or femoral arteries is a primary indicator. Auscultation reveals no heart sounds, and respiration ceases with no breath sounds. Skin color may change to pallor or cyanosis, and the person is typically unconscious and unresponsive to stimuli. Pupils may be dilated with a sluggish reaction to light. Recognizing these signs quickly is essential for initiating CPR and improving the chances of survival. When cardiac arrest occurs, immediate action is vital. CPR should be started as soon as possible, ideally by anyone present at the scene. The management of CPR depends on whether the arrest happens inside or outside the hospital, and whether there is a single or double rescuer. Outside the hospital, basic life support, BLS, is provided. Inside the hospital, BLS is supplemented with advanced cardiac life support, ACLS, and post-resuscitation care, collectively known as cardiac pulmonary cerebral resuscitation, CPCR. The primary goal of basic life support is to maintain oxygenation in the lungs, brain, and heart through rescue breathing and cardiac compressions. This ensures oxygen is transported to tissues before advanced care begins. The BLS procedure follows the sequence of airway, breathing, and circulation, ABC, which has evolved to prioritize circulation first, CAB. Each step begins with an assessment phase to determine the patient's response, pulse presence, and respiratory status. Proper execution of BLS is the foundation of successful resuscitation. Airway management is the first step in BLS. When the victim is unresponsive, position them supine on a firm, flat surface. The rescuer should be at the victim's side at shoulder width. The triple maneuver: open the mouth, head tilt and chin lift, and jaw thrust is used to clear the airway. In unconscious patients, muscle tone is impaired, causing the tongue and soft tissue to obstruct the pharynx. Moving the lower jaw forward lifts the tongue away, opening the airway. Devices like Guedal's or Safar's airway may be used if available. The head tilt and chin lift technique is crucial for opening the airway. Place one hand on the victim's forehead and apply firm backward pressure to tilt the head. Use the fingers of the other hand under the chin to lift it forward and support the jaw. The jaw thrust maneuver involves grasping the angle of the lower jaw and lifting with both hands, displacing the mandible forward while tilting the head back. Remove any foreign material or vomitus quickly, and be cautious with loose dentures during mouth-to-mouth breathing. Foreign body airway obstruction requires immediate intervention. Back blows are delivered to the middle of the patient's back, typically 4 times, to induce coughing. The Heimlich maneuver involves manual thrusts with the rescuer behind the patient, compressing the chest 6 to 10 times. The finger sweep method is used for unconscious patients with a foreign body, applicable to both adults and children. Quick removal of obstructions is vital to restore breathing and prevent further complications. To assess breathing, place your ear near the victim's mouth or nose. Look for chest wall movement and listen for breath sounds. Expired air resuscitation includes mouth-to-mouth, mouth-to-nose, and mouth-to-airway breathing. These techniques provide oxygen to the victim using the rescuer's expired air. Proper assessment and timely intervention are essential for effective rescue breathing. Let's look at mouth-to-mouth breathing in detail. Mouth-to-mouth breathing is a quick and effective way to provide oxygen. The rescuer opens the airway, closes the victim's nostrils with the thumb and index finger, takes a deep breath, and forms a seal with their lips around the victim's mouth before exhaling. 2 slow breaths, each lasting 1.5 to 2 seconds, are given to ensure chest expansion and reduce the risk of gastric distension. If mouth-to-mouth is not possible, mouth-to-nose or mouth-to-airway breathing can be used as alternatives. Some rescuers prefer to use barrier devices, such as masks or face shields, during expired air resuscitation. These devices often have one-way valves to prevent exhaled air from entering the rescuer's mouth. A barrier device should have low resistance for gas flow to avoid fatigue. To use, position the device over the victim's mouth and nose, ensuring an adequate seal. Breaths are given at the same rate and sequence as described for mouth-to-mouth breathing. Mouth-to-mask breathing uses a transparent mask with a one-way valve mouthpiece. Some masks allow for supplemental oxygen. The mask is placed around the patient's mouth and nose, and the rescuer uses both hands to create a tight seal. The jaw is lifted, while performing a head tilt, and breaths are given as in mouth-to-mouth technique. This method is reliable and allows for effective ventilation, especially when supplemental oxygen is available. Checking circulation is a critical step in CPR. The carotid artery, located between the trachea and neck muscles, is the most easily palpable. If no pulse is detected, external cardiac compression should begin immediately. This step ensures that blood continues to circulate, delivering oxygen to vital organs. Proper technique and prompt action are essential for effective circulation during resuscitation. External cardiac compression is performed by applying pressure over the lower half of the sternum at a rate of over 100 compressions per minute. The victim should be supine on a firm surface. The heel of one hand is placed on the sternum with the other hand on top and fingers interlocked. The rescuer's elbows are locked, arms straight, and shoulders directly over the hands for maximum force. The sternum is depressed 0.5–1.5 inches, and pressure is released after each compression. Optimal compression generates an adequate carotid pulse. During CPR, continuous assessment is vital. Inspect for chest rise, depth of compression, and hand position. Palpate for return pulse and assess peripheral pulse. Auscultate for breath and heart sounds. In single rescuer CPR, perform 30 compressions followed by 2 ventilations, then check for carotid pulse. If absent, resume CPR. In 2 rescuer CPR, maintain a 15:2 ratio of compressions to ventilations. Proper assessment ensures effective resuscitation and increases the chances of recovery. ACLS builds upon BLS by adding advanced techniques and equipment. It includes ECG monitoring for arrhythmia recognition, defibrillation, IV access, and drug therapy. The primary survey continues ABC of BLS and defibrillates first. The first ABCD of ACLS covers airway, breathing, circulation, and defibrillation. The second ABCD involves endotracheal intubation, assisted ventilation, circulatory support, and differential diagnosis to find and treat the cause. ACLS is essential for restoring spontaneous circulation and improving outcomes. Drug therapy is secondary to fundamental interventions like airway management, ventilation, chest compression, and defibrillation. Common drugs used include adrenaline, atropine, lignocaine, calcium, and sodium bicarbonate. Adrenaline increases peripheral resistance and coronary pressure, while atropine enhances sinus node automaticity. Lignocaine treats ventricular tachycardia, and calcium is indicated for hypocalcemia or overdose. Sodium bicarbonate addresses metabolic acidosis and prolonged arrest. Proper dosing and indications are crucial for effective drug therapy during resuscitation. Additional drugs used in CPR include dopamine, dobutamine, calcium chloride, amrinone, norepinephrine, phenylephrine, nitroglycerine, and sodium nitroprusside. Each has specific indications and dosing. Complications of CPR can include rib fractures, gastric laceration, splenic rupture, and pneumothorax. Ischemic injuries may affect the kidneys, brain, liver, and other organs. Understanding these risks and managing complications is essential for improving outcomes and minimizing harm. The outcome of resuscitation depends on several factors, including the patient's age, cause of arrest, whether the event was witnessed, rhythm, and ischemia time. Neurological recovery is about 50% if arrest time is less than 6 minutes and CPR time is less than 15 minutes. If these times are exceeded, survival chances are nearly nil. Timely intervention and effective CPR are key to improving outcomes and maximizing neurological recovery. Flowcharts summarize the protocols for managing adult and pediatric cardiac arrest. These visual guides outline the steps for CPR, drug therapy, and advanced interventions. Following established protocols ensures consistency and effectiveness in emergency situations. Familiarity with these flowcharts can help responders act quickly and confidently, improving the chances of survival for cardiac arrest victims.